Hello, I replaced my colleague Victoria Schneider today. Greetings from Victoria. She can unfortunately not be here, and no gymnastics today because it's just me. So I talk today about the innovations not only for lung cancer screenings but also beyond lung cancer screening, in a workflow sense, so what we do with the patient after we identified the lung cancer, but also in a disease sense. This is the slide showing the progress in Europe. So while we had very limited activities in 2018, now we have a lot of countries that have commitments or nationwide screening programs. And also luckily these screening programs now scale up. So England is heading towards 1 million scans per year. They are the first single providers that make more than 10,000 CT scans a month. You have this nice picture here from InHealth. They just should learn that this is an MRI, but the programs are now very large. You see here the statistics from Greater Manchester. And of course, this upscaling also provides challenges in terms of you find a lot of other things. If you do 10,000 scans, you find around 400 interstitial lung abnormalities, for example, and you find a lot of lung cancers. You find hundreds of nodules, hundreds of operations, and so on. So this is very large scale. So this shows a bit the findings beyond lung cancer. This is statistics from Korea regarding the prevalence and the hazard ratio. The solid gray block is prevalence. How common is this found in lung cancer screening? And the white blocks are hazard ratios. So what is the relative risk? You see that there are two diseases we talked a lot about, coronary calcifications, emphysema, that have a very high prevalence in the screening population, but a more moderate risk compared to the other diseases that have a very high hazard ratio, but are fortunately less common. And I will now focus a bit more on the topic of interstitial lung diseases because COPD and coronary artery disease we already discussed and will discuss further. So ILAs, you see here a study from England that showed that in 1,400 screening participants, they found around 85 ILAs. This is around 6%, so it's pretty common. If you scale this up to the 1 million scans, you see that you find a lot of ILAs. However, only a smaller portion, less than 1/3 of these ILAs really progress into an ILD. This ILD patients then are associated with a significant risk of death. So the trick is here, how do I sort out the patients with non-fibrotic changes? You see the survival curves on the right-hand side. Fibrotic, almost perfect survival from the patients with fibrotic changes that will progress into ILD and finally IPF and have a high risk of death. So this is something where new CT technologies like photon counting CTs can play a role. Here you see the difference between a very good conventional CT on the left-hand side, where the lesion presents much more like a round glass lesion. It's difficult to say whether this is a UIP pattern or not. On the right-hand side, you see the same patient in a photon counting CT, and you see very clearly the signs of broncholectasis, and which are decisive for diagnosis of fibrotic disease. So this helps to sort out these patients quickly and neither overwhelm pulmonologists with a lot of suspected ILD, and also really identify the patients that really will progress into ILD quickly. Another topic is, of course, what to do after screening. When I found a nodule, when I have to treat it, and you see that many sites now do this on a very massive scale. If you have 10,000 patients a month, you have several hundred nodules to biopsy. You see here the integrated solution that we offered together with Intuitive Surgical as a partner, where you have everything from path planning on the CT to robotic navigation, cone beam CT for in-lesion confirmation, and finally biopsy, a fully integrated solution. And here you see it in real world with results from Zurich, where they have a diagnostic yield of around 90%, which is indeed very, very good for a bronchoscopic biopsy. And here you see the setting with the robot, the C-arm, and the integration, and this is, I can only recommend to try it. It's really nice, especially for the younger generation of physicians who grew up with the PlayStation. It's really video game-like bronchoscopy. Another topic is image-guided surgery. Yeah, usually you place a wire or a fiducial marker in the nodule to find it again during surgery. Yeah, this needs needle intervention, needle path planning, and then finally the thoracoscopic resection or robotic resection. Yeah, for this there are also fully integrated solutions with full field intraoperative cone beam CT, where you can do everything in one step, in one session with the patient on the table. Then you remove the C-arm, do your operation, and do everything in one wash-up. Another big treatment modality is, of course, radiation therapy, stereotactic body radiation therapy. There a problem have always been artifacts. The patient breathes during therapy, so you need to plan in 4D, time resolved. Here you see on the left-hand side the typical artifacts. On the right-hand side, you see the new technology that avoids artifacts and have a very good 4D planning capabilities integrated with the Linux. And now I'm already finished. Yeah, so we see lung cancer screening scaling up. We see very high numbers of nodules, cancers, and concomitant diseases, but we also have the technology to handle this and to make things more efficient and handle these very high numbers of patients. Thank you very much.